Yeah, wow, it's so awesome to be in this company. And I don't know if this was your intention, Andy, but I feel like all of our work is so closely connected too. And so I feel like I'm going to be telling people a lot of things that we've already heard. But just to reiterate it even again, because we know it's such a big, important challenge, is that there is a tremendous gap in mental health care for children around the globe. And though there are treatment gaps in nearly every area of every country, we know there are larger treatment gaps in lower resource settings, like low to middle income countries, such as Kenya, where I've worked, as well as in the United States, like rural areas in North Carolina, where I grew up. And it goes beyond just place too. We know that marginalized identities and marginalized populations are also less likely to have access to mental health care. And even when folks do access treatment, there are major gaps in ensuring they're accessing evidence-based mental health care, meaning that even if kids do access care, it may not be evidence-based, or it may not be a treatment that has been proven effective in research trials. And so moving into this, partially in response to this gap, there have been, and the challenges in accessing effective mental health treatment, the field of implementation science has become increasingly prominent in recent decades. And Zabin talked about this, but implementation science is defined as the scientific study of methods and strategies that facilitate the uptake of evidence-based practice and research into regular use. And to kind of just put into context more, it's different from treatment effectiveness or even health services research, and that it focuses specifically on these implementation outcomes or indicators that can better describe the reasons why evidence-based interventions may not be implemented in routine care settings. These are distinct from clinical outcomes, and that they focus a little more on the process of implementing an intervention. And so an example may be a challenge with acceptability from a potential provider, or providers not liking or being satisfied with an intervention, which then results in them being less eager to use it. And looking just at the count of publications with the phrase implementation science on PubMed, you can see there's been this huge surge in interest in publications on implementation science dating all the way back to 2000. But at the same time, we still have massive gaps in care, and we still have massive challenges actually implementing evidence-based treatments. And so it kind of calls into question, of all this investment in implementation science, what has been our outcome of this? And so to visualize or to contextualize implementation science more, I'll ask you all to engage in a thought experiment and just think about how you would implement a new practice into your daily life. And we can take the example of a run, which is, I will admit, much simpler than asking someone to implement a treatment into their daily life or into their work. So the intervention in this example is, or the thing, to borrow from others' research, is running, just a daily run. And from implementation science, one of the innovations of the field has been calling attention to how implementation determinants, so like barriers of facilitators, impact the likelihood that something is taken up into someone's routine or into a routine care setting. And one such determinant may be time. Perhaps you don't have time to integrate a run into your workday. Or perhaps you're not motivated to integrate a run into your workday, especially because I am just telling you that you should implement a run into your routine workday. And maybe you're not seeing the benefits of that. Or finally, knowledge. Maybe you know how to put one foot in front of the other, but how long should you be running? How do I learn a running program? What if I want to train for a longer run? Like, there is a lot of knowledge, even in something as simple as a run, that we know could be a barrier. So another innovation from implementation science has been thinking specifically about implementation strategies. So if all of these determinants exist, what are the strategies that we can use to address these determinants and make the implementation more likely to stick, or make it more likely that someone goes on a run? And so one example strategy may be something like scheduling. Perhaps we suggest that you schedule a run into your day at 6 in the morning. Maybe another strategy is having a champion, which is really common in implementation science research. It's basically like someone to champion the practice, someone to motivate you every day to get up and go for a run. Or a third strategy is maybe if you don't know how to run, maybe you just get an Apple Watch. Like you can download some songs, you can download training programs, it'll even track how far you're going. Like you can learn the different running training programs along the way. And now you could already be starting to see how things can fall apart sort of quickly. Like what if you can't afford an Apple Watch? What if you're disabled and you can't run, but I'm still telling you have to? Kind of like where's the focus on equity in all of this? Because ultimately, like these are my determinants and my strategies. And even though I sat back and looked at the research on what is kind of a common challenge to people going on a run in their daily life and thought about how I could make this apply to multiple people, it's still all colored through my own perspective and my own experiences. And for my own anxiety, I don't even want to look at the number of people in this Zoom room, but there are X number of other potential determinants and strategies for every person that would be taking this up into their daily life. And even more beyond this Zoom room that we would eventually want to scale this up to. And if we think about even something as simple as running, there are millions of people we need to adopt this approach to. And maybe this person, maybe actually his strategy, maybe my strategies do work really well for him, and that's great. Maybe for this guy, maybe having an Apple Watch would be out of his finances. Maybe that strategy wouldn't work for him. Or maybe we don't share any determinants or any of the same strategies with this person that I've circled here. Because ultimately, and I think we all know this, especially in life, there are no one-size-fits-all solutions. And attempts to develop these one-size-fits-all solutions tends to privilege those in the room, me making the slides, or those with power and those with privilege. And this has been a critique of implementation science as we've grown and tried to establish implementation science as a science. It's becoming increasingly incompatible with many settings, with many people. And it's proposing strategies or approaches that are overly complex and disengaged from partners or the people on the ground, the people we're asking to implement evidence-based treatments, or even the people who I'm asking to run in my example. And my own work has shown a bit of this in just looking at how implementation science and how projects that try to implement evidence-based treatments actually engage with stakeholders, broadly defined, whether that be providers, community members, children themselves. And in surveying 103 different implementation efforts, comprised of 122 different papers that we systematically reviewed, we found that most projects actually only engaged with providers, forgetting a huge subset of other potential stakeholders, with limited depth. So they often gathered information without sharing decision-making power. The modal project asked people to implement something, and then after the fact, after it had already failed, then tried to understand what happened. And of course, I will acknowledge that this is what people report, and perhaps we're not reporting the extent to which we're engaging with people. But we do know in general that we're not actually sharing decision-making power, and we're not often truly deeply engaging with our partners in our research. So my burning question that motivates so much of my research has been, how do we consider the needs of all to advance health equity? And my answer, unsurprisingly, given the setup, has been we ask and empower them. Because ultimately we all know ourselves best, and it's impossible to even know all that we do not know sometimes. And this is kind of where I see my research going in the future. So, and this is where kind of the role of participatory implementation science, I think, enters. And how can we apply and refine participatory implementation science so that we're understanding the unique needs and preferences of all the people we're working with? And what do I even mean by that? So to give a really short example, For my dissertation study, I led a participatory research project with lay counselors in Kenya. So as Atina was talking about, folks that do not have formal mental health training. And alongside with folks, our research partners in Kenya, we conducted qualitative interviews. They hosted a human-centered design focused workshop to understand like, what are your unique contextual needs and how do we support those? And then together we developed and evaluated a flexible support package that actually empowered our lay counselors to determine what their own barriers were and match their own solutions to address those barriers, specifically within the context of getting supervision for the treatment that they're providing. And kind of this approach and this method specifically is what I'm really excited about carrying forward in my career, to continue asking questions of like, how do we improve children's mental health broadly defined, and thinking about the environments in which we live, work, and play, the social determinants, which is more of a public health approach, like as it being mentioned, is how do we address those social determinants or the structural factors that impact children's need and access to therapy? Or moving to lower served areas where providers may be fewer, like our beautiful Olympic Peninsula in Washington State. How can we advance innovative methods like working with lay providers or community-based providers in the US to increase access to care for children that need it most? And how do we ensure that we're actually providing high quality mental health care to all, which I do define as moving beyond just evidence-based and actually ensuring that our evidence base is inclusive and that our treatments are also culturally robust. And finally, in all of these efforts, how do we balance our needs for tailoring and generalizability, engaging deeply with partners, and thinking critically and strategically about how we do this so that we move our science beyond the lab and into the hands of communities and policymakers and all of these other folks who have power and knowledge and ability to enact change. So thank you all. Thanks.